Okay, so the methods they used were they did this they divided the stages. Group 1 were those without chronic disease. Group 2 were those stage and those with stage 2, and in group they did those with stage and those with stage 4 stages, and 3 were those with stage 5 and those with end-stage renal. And the primary outcome was all cause in hospital mortality. So this I put this article. So you can see the study was done from October 2015 to December 2017, and the total number of people that were in were 1,174, and they tried to exclude those that were less than 18 because they tried to find the impact in older population, and they excluded those younger than 18 that they excluded were 179. So when the after excluding those less than 18 became 51,995,000. And those were that they grouped into the 3 stages. And those under the group 1 stage, like I mentioned, were 4,373, 75. Under 2 was 5,465, and those under group 3 were 22,155. So this table, the progression on 1, group 2, and group 3, in age has a big factor on chronic kidney disease. And you can see that most presentations were most chronic disease are actually those older, and those that and it was 227.84, and those younger were 32.26. And it will make sense because the population that actually present mostly with chronic kidney disease are those of older population. Also, sex has a big variety because most people that have chronic kidney disease also are males, and the total number from the groups were 163.17, and in female it was 136.83. And you likely that under the group stages, male present are mostly in group 1 compared to female, and will make sense because of the age, because male most likely present with chronic kidney disease, they're most likely to want to screen them with chronic kidney disease compared to females. When females actually want to screen themselves for chronic kidney disease when they actually have symptoms, and that is why most of them fell under group 3 stages, and that is the late stage of chronic kidney disease because they already have like a symptom. That's why most of them fell under group 3 compared to male, which fell under group 1. And also, race has a huge risk factor. It was discussed that white race are most likely to fall under group 1 stage compared to other race, like Black, Hispanic, Asian. All of them fell under group 3 stages. You are most likely that white races also have most likely screen themselves compared to other race. That is why they most likely fell under group 1 compared to 3 stages. And also another variety that can also play a risk factor is insurance. They realize that people like Medicare, people that use Medicare, they all fell under group 3 stages, and those were the late stages of chronic disease compared to other insurance like private insurance, Medicare, which fell under group 1 stage, maybe because they're most likely to actually get fixed faster compared to people that are using Medicare. And also, there's so many comorbidities that actually impact people that actually present late with chronic kidney disease. Things like hypertension and diabetes, chronic heart failure, chronic pulmonary disease, anemia, obesity, smokers, all those comorbidities actually impact chronic kidney disease. And also, they found out that if you have hypertension, you're most likely to fall under 3. If you have diabetes, you're most likely to fall under 3, and those with chronic pulmonary disease, they fell under group 2, and people with obesity and smokers, they all fell under group 1, because those are not a big, strong comorbidity compared to people like hypertension and diabetes. So those in group 6 stages has higher mortality, higher risk for amputation because of ischemia, and more complication with endovascular therapy. So you can also see this particular table that I inside in this. You also find out that like amputation, they are most likely to impact chronic kidney disease. Table, hospital costs, the first table, they try to divide it into only group 1. They try to compare group 1 and group 2 stages. And under group 1 and group 2 stages, things like manual amputation were most likely in 1 compared to like complication were most likely to present in group 2 stages compared to group 1 stages. Hemorrhage most likely to present two stages compared to group 1 stages. And then they try to use 1 versus group 3 stages for the second table. The impact, varieties of impact of when you divide into 1, 2, and group 3. The result in total was significantly higher in 2 and group compared with 1. All of minor amputation, vascular complication, and were more higher among group 2 and group 3 compared with 1. And group 2 had higher compared with 1 and whereas group 3 had higher odds of major amputation, post-procedural infection, and with 1 and group 2. Also, 2 and group 3 had lower odds of discharge to home compared with group 1. And finally, the length of hospital stay and cost of care was significantly higher with the advanced chronic kidney disease. So in conclusion, advanced chronic kidney disease stages and end-stage renal disease are associated with higher mortality, worse in-hospital outcome, and high resources utilization among acute ischemia, hospitalization undergoing endovascular therapy. So the clinical impact of this study the study was a good study because they tried to have a larger group to actually fit into different things, like they tried to comorbidity, so they had a higher to try to like get the best stages of, and also advanced kidney disease is a significant risk factor for worse in hospital and mortality, and patients with acute limb ischemia and advanced kidney disease is associated significantly higher resource utilization as compared to patients with normal or mild kidney disease. So thank you, and this is the end of my
again, and the maybe and we all learn from the talk here and that many way and higher definitive profile complication with endovascular prevention. Next presenter Tashvin on aortic dissection. Again, problem that's common in the medical field, where we have young people just suddenly get tearing pain in the chest that results in death. So we want to use opportunity to highlight issues associated with aortic dissection.
Thank you, Dr. Oye, and I apologize to everyone that has joined us and to wait for the presentation. Good now, so start sharing the screen. Any questions? First.
You're muted.
Hello?
Yeah,
You guys hear me?
yeah, it's good now.
All right, sorry. Okay. All right, so guys, my presentation's on aortic dissection. As Dr. Oye stated before, it's a growing issue in our medical community, and it's basically a tier of the aorta between the intima, and which leads to accumulation between those two areas, the intima and the media. Now, aortic dissection is divided into two types, which stand for type A and type B. Type A being the critical one, which requires most of the time surgical intervention, whereas type B is more medical management. Now, cases also are divided into either or chronic, depending on what type you have. Few presentations are more deadly, they carry more fatality rate, and most of the patients die before reaching the emergency department. Chronic cases carry a better prognosis and are generally favorable. So in classic presentations, we'll see that you have tearing chest pain, it radiates to the back, and most of the time, a subtle presentation could be more type B presentation because those presentations are less severe. So those are often misdiagnosed with type A, which is very more apparent. On chest X-ray, you'll see mediastinal widening, also like a enlargement of the aortic, and 15 to 43% of aortic dissections are diagnosed in the emergency department on first presentation. So you can see that a lot of the times they're missing the ER, and it's something that clinicians should be more aware of. All right, so we'll talk about type A for a bit. So this involves the ascending aorta. It's proximal to the brachiocephalic artery. I'll bring a picture on it later. Type A dissections can be further classified DeBakey type 1 and type 2. DeBakey type 1 originates in the ascending aorta and the aortic arch, and or the descending aorta. Type 2 DeBakey is solely in the ascending aorta, so it's limited to that area. Ascending aortic dissections are almost twice as common as descending aortic dissections, but you'll see more type 1 presentations. Surgery is almost always indicated, as I stated before, and within the endovascular field, catheter-based approach using a stent graft or a dissection, flap fenestration, or branch vessel repair to make the aorta open up again and get more blood flow to those areas. Acute dissections of the ascending aorta carry a 1% per hour mortality, which means that every hour the patient, is going through with less blood flow to their extremities, their mortality keeps increasing 1% every hour. Now, in terms of a type B dissection, achy type 3, there's 3A and 3B. 3A begins in the descending aorta and ends above the diaphragm, whereas 3B would below the diaphragm. So blood pressure control is usually, this is the medical management, and is surgery in most cases. Usually with type B aortic dissections, you don't need to do surgery unless it's gone to a patient that's complex. And this is done to decrease the wall stress on the aorta. So along with blood pressure and medications, regular CTs and MRIs are needed to check for changes in the aorta, so patients can be monitored if they needed to. In the course of a year or two, if the patient is not taking their medications, they're not having good blood pressure control, it's going to be obvious on imaging, and you could take further management from there. But if a person did need surgery, it's because their aorta ruptured or serious complications other than that, or just, like you would need more blood flow to like your extremities or vital organs. And stenting is the preferred intervention as it allows for the aorta to open and seal off blood entry into the dissected wall. Descending dissections carry a 10 to 20% mortality. So in terms of complications, you can assume that, if you're having like high flow and a blood flow in between two layers of, vessels, that it can rupture and it can lead to internal bleeding and death. So blood accumulation in the wall of the aorta can disrupt the flow of the blood to the thorax and abdomen. And this is what I was stating before, that you wouldn't get blood flow to those organs, then you could have like kidney failure and heart failure essentially. And another complication is cardiac tamponade can occur as blood leaks back from the aorta into the blood the wall of the heart, leading to tamponade. So myocardial infarction can ensue because if coronary vessels are blocked as a result of the dissection, they're going to have adequate oxygenation. And a stroke can happen. The cerebral blood are. In terms of epidemiology, so the incidence is estimated to be 5 to 30 cases per 1 million per year. However, the true incidence is much likelier, as it's difficult to diagnose and make a proper diagnosis. So, as I said, it's often missed. So, you could have potentially more being reported. The age range, what we're looking at is between 40 and 70, and with a peak age between 50 and 65. Patients with Marfan's, this shows up in USMLE all the time. You hear about this, but patients with Marfan's tend to present earlier. That case, but see a young, they have aortic dissection, they most likely have. And aortic dissections are more common in men than women, the ratio of 2 to 3. And Black people are more commonly affected than white people, and it's less common in Asian. In terms of risk factors, those going to get the problem. People with higher blood pressure, obviously, so more wall stress, aortic dilatation time, people with atherosclerosis, people with smoke, inflammatory diseases, iatrogenic aortic injury, so from like surgical intervention, and congenital cardiac defects, like perfect, like I stated. So this is a general picture, but which one each. So there's type A and type B. You can see that the type B section below, and it could possibly go below the diaphragm into that. And type A, so in the ascending section of the aorta, and it can go further down. So they're divided like that. And here we have a CTA that also, the true lumen is generally the false one. It's just because more blood flow is going to be in the true lumen, and it's this is like the gold standard. You have a dissection. That was my presentation on aortic dissection. All right, I do have one more quick presentation that's going to be on pulmonary embolism. Let's do. All right. So pulmonary embolism occurs when it's a location and travels to the lungs and blocks up the pulmonary artery branches. The diagnosis is often missed and not specific. A lot of times they present like a heart attack, or you know, there's all these other sort of causes of shortness of breath. So primary cause of death in E is because of right failure or dysfunction. Uh, as you can assume, that the blood flow from the lungs don't reach the heart and can't pump out. Thus, you're going to have less oxygenation, you're going to become hypoxic, and prognosis depends on the degree of the obstruction. So, presentation of P, of dyspnea, chest pain, tachypnea, tachycardia, hypoxemia, and respiratory alkalosis. Alkalosis because you're trying to hyperventilate, trying to acidosis. So who is at risk for pulmonary embolism? family history of blood clotting disorders, surgery or injury, more significant in the legs, which is where the emboli likes to go to the lungs, or orthopedic surgery. A lot of the clots from the orthopedic surgery have been that, post-op people have been getting PE. The situation in which mobility is limited, DVT, such as like extended bed rest, flying, riding, or paralysis. So stationary, you're going to the previous history of clots, old age, malignancy, or chemotherapy, medical conditions such as COPD, high blood pressure, stroke, and IBD is one risk factor. And medications such as birth control pills and estrogen replacement therapy, and cigarette smoke, bleeding. Okay. In terms of epidemiology, 10 million cases a year worldwide, a lot of people. And a third of these hospitalized patients are developing VTE. So most patients in the hospital, they end up getting a DVT, but not necessarily a PE. So 60,000 cases of VT are diagnosed per year. The incidence, 17,000, but like aortic dissection, the true incidence could be much likely higher in these cases because of going undiagnosed. And PE cases raised from 60,000 to more than 200,000 to 2012. So it's only been increasing, and as medical management system, like that number now. But the older population, just like aortic dissection, affected. The people over 70s are 3 times more likely to be affected than those between the ages of 45 to 69. 50% of in-hospital deaths are actually due to pulmonary outcomes. So it's a high rate of deaths from. I remember like hitting an ER rotation, and they said someone comes with chest pain and shortness of breath. The 3 things that you got to check out was you got to rule out an aortic dissection, PE, and a triple A. So that's, if it's high on their radar, I'm sure it's people are gonna be aware of it. So okay, so let's look at after. So we have acute mismatch, ventilation mismatch. This essentially is when the clot goes to the lung, one of its arteries blocks off that. So right now, the alveoli in the lungs, they're getting ventilated, but not necessarily infused. So you're going to have ventilation fusion match. Now, when this happens in the lungs, you all know that you have pulmonary vasoconstriction, so they're going to shunt blood to areas lies the body can see in some way. Maximum cause reduced cardiac output, leading to low mixed venous oxygen saturation. Less oxygenated from the lungs reach the heart and go into systemic circulation, and so the person's going to eventually become toxic. Now, this all depends on how badly that artery. So if it's a massive blockage, then you're not going to have oxygenation. If it's relatively low, you're still going to get somewhat, but not as much. So it really depends on how bad it's blocked off. Now, hypercapnia is rare. It's medullary receptor that's the increase in partial pressure of carbon dioxide and increased minute ventilation. Now, I mentioned that you're out of respiratory alkalosis with PE, and that's because you're taking out all the carbon dioxide in an effort to balance out that metabolic acidosis from not getting oxygen. Now, in terms of imaging, chest X-ray is often normal, so they're not relatively why you would use one. But the gold standard is a CT pulmonary angiography, which is what you see on the right. Now, the classic that medical professionals like to use, where you see that between the area, and you can see it really. So this is the standard, and a lot of people like to go medicine to be dispatched badly the airflow related. So, MRI can be used in certain circumstances. MRI is really used and tolerate the dye. And it, all of medical management, we're going to go more into surgically. So manage. The goal is to prevent the creation of thrombi, prevent thrombi from growing in the extremities, prevent embolization, embolus to the lungs, and necessary. So drug therapy, we have anticoagulant therapy. It's the mainstay of treatment. It's very effective in treating blood clots. Heparin and warfarin are the drugs of choice. Heparin should be started immediately if there are no other contraindications, and it can be started even while the person is on DOACs, so direct. The effectiveness of fibrinolytics are not clear, but may be used in hemodynamically unstable patients. So that's like basically a last effort to see if these agents are not working. Possibly there is a effective. Now, in terms of surgical intervention, being a cave filter system could be used. A greenfield filter is the most commonly used filter if one was to be used in the case of a. Now, the greenfield filter is basically like an umbrella filter. It just spines out a little bit, and it's supposed to open up that stent better, so it's better, and blood flow will be better achieved, so the person can achieve oxygenation throughout the body. Pulmonary embolectomy, suitable for patients that cannot receive anticoagulation, or thrombolytic therapy, embolize very much, and the patient is not. So that would be the last effort to save the patients. That is my presentation. Thank you. Does anyone have any questions?
Yeah, I have a question.
Question. Okay, go ahead. Go ahead. What's the question?
Yeah, I have a question. Can I ask? Can I ask my question, Paul?
Yeah. Go ahead.
Okay. Oh, thank you, Paul, for the presentation. Good day, Dr. Oye. Nice to see you again. Thank you for the two presentations. I have a question for you for each of the presentations. The first one is aortic dissection. If I have a patient that is hypertensive, I have what you said about dissecting, that is descending aortic dissection, that surgical option is not the first priority. If I have a patient that is hypertensive, well controlled, and I find out that he has aortic aneurysm, I was just wondering, what would there be any threshold of that aneurysm for intervening surgically? Would there be any threshold?
Well, yeah. Okay, thank you for the question.
Nice one. Did you hear me well? Okay. The second question, given the risk of being admitted, from the presentation, like 50% of patients that are admitted are at risk. Yes, we know that. I'm just wondering, because that implores us all to screen all patients or to do some kind of prophylaxis for all admitted patients. I just want to ask, what do you do in your practice commonly? What do you do in your practice for your admitted patients as a way of preventing pulmonary embolism?
Well, I'm still a medical. I don't have, but what's that? Okay, so in terms of your first question, if you asked, there's a threshold if there's an aneurysm, when would you do surgical management? Now, I believe it would depend on the surgery. Now, obviously, surgery is something that we lean towards and managing. But so if the aneurysm is not, have a high likelihood to rupture or cause more problem, then you would still keep them on medical management. Now, we determined that risk is higher. Aneurysm has potential to rupture or cause later. Then possibly, the aneurysm will need to be repaired. There's a fine balance. I just don't well positive Dr. Oye, but it would still keep screening these people with MRIs. So if they're not symptomatic, if they're doing okay, then. Now, in terms of pulmonary embolism, in terms of screening, if they're a very active person, if they're not stationary, like if you see all those risk factors. Now, if I was talking to someone with those risk factors with one or more, I would put them on hospital anticoagulation if you ask. That's active. So do eat better foods and stuff like that. Aside from that, like as far as screening goes, if there's no indication to screen them, if they appear to be healthy, if their general checkups fine, then I don't see a reason to put on anything practically. Now, if they can't do lifestyle management, then yes, we have to put their argument to see if they don't rest to eat, but necessarily just don't fix something out of the population. Prophylactic, unless there's an indication. So that's what my stance would.
Yeah, I think I got you. So there should be no qualms about the size of the dilatation. As long as the patient is asymptomatic, we should just continue to monitor the patient.
Patients with
I stopped hearing you. Okay, it's breaking. Okay, you are breaking. I've not been able to hear most of what you're saying.
Okay. With
Yeah.
and that
Okay. I can't hear you.
We'll address the question. Dr. Gorgie, offline. We'll discuss that offline. We're having difficulty
Okay.
hearing you.
All right. So that's
Okay. Yeah. No worries. Yeah. Okay. Our next presenter today would Dr. Chinenye, um, talking to us on a appropriate topic shortly. Get her loaded and uh, uh, I think
The next presentation is by Leela. Dr. Saad. Dr. Akhtar, can you hear me?
Yeah, I can hear you.
Hi, are you able to share Dr. Ezike's presentation?
Just a second. Can you see it?
I can see it. All right. Good morning, good afternoon, good evening, wherever you are. My name is Dr. Ezike, and I am a surgical pediatric foot and ankle surgeon. And my presentation today is on a foot deformity called Charcot neuroosteoarthropathy. So what this disease process is, it's a nerve damage related progressive foot and ankle deformity that eventually leads to ulceration, infection, and if the foot deformity and infection goes unmanaged, eventually leads to death. So there tends to be a sexual predilection in that it's found more commonly in males than females, and about 20% of diabetic patients are found to have this foot deformity. It also has a unilateral presentation. Can you guys hear me?
Yeah, we can hear you clearly.
Okay. So there tends to be a unilateral presentation in that it tends to occur in one limb as opposed to bilaterally. Okay. So etiology, everything, it seems to stem in disease processes that have to do with nerve damage, most commonly in diabetes. Other causes is tabes dorsalis, syringomyelia, infectious processes such as polio or leprosy, spinal cord tumors, or alcohol abuse. Nevertheless, the underpinning issue is some sort of nerve damage. So there are two theories that most commonly account for how the disease process occurs, one of which is the neurovascular theory. That's whereby there's autonomic neuropathy that causes loss of smooth muscle tone in the blood vessels, thereby leading to vasodilation, increased blood flow, and with increased blood flow to the bones and the joints, there's an influx of osteoclasts, which lead to bone resorption, softening of the bone, and then destruction of the foot. The other theory is neurotraumatic theory, which essentially means the patient walking on an insensate foot, thereby causing further destruction of the foot. Okay. Clinical picture, essentially you see like a red hot swollen foot that's non-tender to touch, and the patient will deny any precipitating trauma. As far as vascular assessment, patient typically has good pulses. In fact, it's pounding. There's non-pitting edema. There's redness and swelling. And typically between the Charcot and the unaffected foot, difference in temperature is that the Charcot, neurologically, there's growth loss of sensation, and as far as morphology of the foot, it's like rocker bottom type of foot. And typically, clinically looking at the patient dermatologically, there'll be ulceration in the area where the joint is collapsed. On. So labs, there'll be elevated white count. The ESR and CRP will be elevated, and obviously, typically are diabetic, especially uncontrolled diabetic for a sustained period of time. Differential diagnosis, cellulitis, osteomyelitis, arthritis, or VTE. But the literature reports on average, there's a delay in diagnosis of Charcot foot of about 29 weeks. So how do you diagnose this patient? By history and physical exam. Imaging studies, you get some x-rays. There are usually multiple joints involved in the destruction, as opposed to if it's osteomyelitis, there tends to be possibly one bone of affected or one or two joints. But with Charcot, it's multiple joints that are affected. And with an MRI, how you can differentiate between Charcot versus osteomyelitis is Charcot, it's the joint where you see the disease process occurring, but in osteomyelitis, it's more of a specific bone that's affected. Other imaging studies that can use is you can use white blood cell count, white blood cell labeled bone scans. But the most definitive diagnosis is the bone biopsy. If it's osteomyelitis, the bone biopsy is going to come back with a lot of inflammatory cells in it. And with Charcot deformity, you'll see, like with the bone biopsy, it's more of dead bone and some healthy bone as well. Okay, moving on. So as far as classification of Charcot, there's 3 stages, well, actually 4 stages. With stage 0, the foot is red, hot, swollen, patient has bounding pulses, and they're going to tell you that there was no trauma that incited the changes in the foot. And what's actually interesting is that the x-rays go unremarkable. You're not going to see any deformity at that time. If you get a 3-phase bone scan, there's increased uptake in all phases. So again, keep in mind in stage 0, let's just go back to the other slide. In stage 0, again, it's red, hot, swollen. There is no precipitating trauma. X-rays look like normal. Okay, next. Now in stage 1 is when you can start appreciating bone destruction. That's when now you can see the bones being pretty much destroyed from the increase in osteoclasts. As you can appreciate in this picture. Oh, you can't. So in stage 1 again, this is where you can appreciate bone destruction. And at this time, where the joints are destroyed, the foot pretty much is very lax and very hypermobile. Again, patients are insensate, so they're going to deny any pain. At this stage of Charcot, the treatment of choice is strict non-weight bearing. If this patient cannot adhere to weight bearing status, then you can apply a total contact cast. This is a specialized type of cast that's about 40 to 50% of weight from the foot to the tibia. You know? Now in stage 2, the bones are starting to remodel and coalesce. So there's less swelling, there's less redness. The bones are beginning to open. At this stage, the treatment of choice is the patient can begin partial weight bearing in a total contact cast, or you can have them ambulate in a Charcot restrained orthotic walker. It's a very big old foot. Okay, stage 3. Next. Now, stage 3 is the final stage, where it's also known as consolidation, where the destroyed bone has coalesced into a rocker bottom texture. And the treatment of choice conservatively, again, is the Charcot restrained orthotic rocker or a orthotic shoe with a rocker sole. Next slide. So as far as joint involvement with Charcot, the predominant joint that's affected is the lift frank joint. That's the joint between the metatarsal and the midfoot. And then other joints affected after the lift frank, the following most common is the heel part joint, which is more proximal, closer to the ankle. And then the third most common area is the metatarsal joint. The fourth most common area, which is debilitating, is the ankle joint. And last is the heel bone. Okay. Again, conservative treatment is really non-weight bearing until the third phase of the Charcot deformity has been, but this tends to be kind of very difficult. Patients, diabetic, they can't stay off their foot. They have gait imbalances. So it's not really practical to keep them now bearing for that. Now, surgical intervention is indicated if there's a large ulceration on the bottom of the foot due to the rocker bottom foot architecture, or if the foot is. So your goal with surgical intervention is to establish a plan for a foot where the entire foot can purchase the ground as a. The less invasive surgical intervention will be to lengthen the tendon, lengthen the Achilles tendon, so that you can have proportionate weight bearing across the surface of. You can also do Charcot planing, which essentially means just resecting prominences where the ulcer is. But the more invasive surgical intervention will be procedures like Charcot steaming, fusing of the ankle joint, bone graft. And but when you choose to do this invasive Charcot reconstruction, the patient has to be made aware that there's a 50% chance that it's going to fail, and they may end up eventually. Okay, next slide. I have some pictures here, but there's no point. We can't even see. Oh, they can. Okay. So this is just showing some pictures of Charcot reconstruction. This right here is showing a Charcot steaming, where essentially you're going to break multiple bones and realign them for more anatomic structure, and then stabilize the constitutive large. And this is just showing an ankle arthrodesis. And this here they use a small cast and an intramedullary nail to stabilize the whole structure. Another option is to use an external fixator, keep the well aligned, and help the patient stay off their foot. So I have a couple cases of Charcot I did at Valley General Hospital. Next slide. So this is a case of a 50-something-year-old female patient who had presented with gas gangrene on the bottom of her foot from a Charcot foot deformity. So I took her to the operating room, cleaned out that necrotic tissue, put a wound vac on it, and I put an external on her lower extremity with legs, so that way she can walk on the external fixator while having her foot suspended off the ground. So right now she's healing quite well. Once she's healed, the plan is for her to be referred to another hospital system to undergo a Charcot reconstruction. Next slide. This is another patient who presented with a wound on the bottom of his foot that has been present for 5 years. And we had tried offloading techniques, skin substitute graft, infection control, but the persisted. So I offered him a Charcot reconstruction versus a partial foot amputation. And our patient understood that should the Charcot reconstruction fail, he's going to end up with a below-knee amputation. So with this information, he decided to just go with the partial foot amputation. But so as you can see on the slide on the left, this is where the joint is collapsed. Joint is collapsed right here. So I went proximal joint collapse so that he will have a more plantigrade foot. So that's exactly what I did here. And he's healing quite well. He's not quite healed yet, but he's on the way to heal. Next slide. So in summary, the key to identifying and treating Charcot neuropathy really is early recognition of the disease process. So again, if you have a patient who is coming into your clinic, uncontrolled diabetic for a long period of time and insensate, if your foot is red, hot, swollen, and they tell you that there was no trauma. For example, there was no direct trauma, but your first clinical index of suspicion should be Charcot foot. And the first thing you must do is tell the patient to be strictly non-weight-bearing foot. If you can apply a triple contact cast, that will be ideal because then the patient can walk on the cast and have the weight transferred to the shin. Okay, and that's it. Thank you. Any questions? The cheapest method will be, unfortunately, staying off their foot. But my patient, compliance is an issue. One, they can't feel their feet. Two, balance is a problem. So in that case, I just put them in a surgical.
Can I ask this brief question?
Yeah.
Yeah, thank you for the presentation. That is quite really brilliant and well done for what you're doing. Second time listening to you.
Thanks.
In concluding, you summarize the features we should see in a diabetic patient that
Correct.
should make us suspect that this patient may be having Charcot osteoarthropathy.
Correct.
I didn't quite hear what you were recommending for, to be done as if it is detected early. What was that you mentioned? Maybe I can hear you now.
Okay.
What should be done for such a patient that is picked early?
Ideal. Can you hear me? Okay. The ideal treatment is strict non-weight bearing, which means not at all on that affected foot.
Okay, I got that. Non-weight bearing.
Yes, non-weight bearing. Now, if the patient cannot comply with the non-weight bearing status, for example, if they have unsteady gait or they have other comorbidities like Parkinson's, then in a tall surgical boot, or if you have the skills by a total contact cast, that would be great. The total contact cast is essentially a walking cast that helps transfer some of the weight from the foot to the tibia.
Okay. For how long should a non-weight bearing last?
That's the problem. It's typically 3 months.
3 months.
So
Okay.
yeah, it's not really practical. So if you can apply a total contact cast, that will be better for the patient in terms of compliance, because then they can walk on the cast.
Thank you. I got it.
It comes partially pre-made. You have to apply it on the patient, and it has to be changed no later than every 2 weeks. It's also good if they have a wound. You can apply the cast even if they have a wound, as long as the wound is not infected.
Yeah. Okay. Thank you. Got it.
Okay. Thank you.
All right, guys. Next presentation will be Leela. I'm just going to open up the presentation and we guys, can you guys see this?
Yeah, it's clear.
Okay.
All right. Next present.
All right, guys, can you hear me?
Yeah, I can hear you.
Okay, so my name is Leela Duraimurugan. I'm third year medical student with Avon University School of Medicine. And thanks to everyone for presenting today, and thanks to Dr. Oye for giving me this opportunity to present today. So my topic is gonna be on the treatment of pseudoaneurysm in AV graft with endovascular stent placement. So our main objectives for today is gonna be first understanding what pseudoaneurysm is, and then how to recognize their signs and symptoms, and how to diagnose them, understanding the risk factors and preventative approaches, and also exploring different treatment management options currently available treating the pseudoaneurysm. And then I'll discuss a case that I observed. Okay, so we all know what an aneurysm is, right? Like it's just a balloon-like dilatation of the vessel. And there are two types of aneurysm. One is true aneurysm, which involves all three layers of the vessel, and the other one is aneurysm, and it only involves the outer, which is the adventitia, as the picture. And pseudoaneurysm is more prone to develop in AV graft undergoing dialysis. It's because there is the repeated puncture by the dialysis cells, and so the patient ends up getting that. The other main reason pseudoaneurysm can occur in these patients can be due to venous stenosis. Venous stenosis can cause pressure, which can also the aneurysm, and can be really damaging for patients. This can end up in thrombosis because the blood can, can lead to and that occur in some of the- but there's really low incidence. So the patient will present with thrombus in the AV graft, and there will be noticeable swelling or lump formation, and we can also using skin changes like, and there can be increased blood to the graft aneurysm. Can you guys hear me? Okay. And what are the alarming signs that necessitates immediate surgery? So if the rate of expansion is really fast, or if the aneurysm is really larger than the size of the graft, and the skin over the graft is like threatened with fiber, or if the patient has aneurysm, these all signs indicate that the patient is in intention of surgery. And how to diagnose them. So we can use an ultrasound and to diagnose the pseudoaneurysm. So here I have included and blood acute the AV. And we can also follow assess all the complication. And it really has highest and has 9, and it helps in the visualization of the vessel and the fluid collection external to the vessel. And this is sign, and you can also do a spectral Doppler, which can detect life patient. And what are the risk factors for pseudoaneurysm? As I mentioned earlier, needle cannulation, the same site, have development of pseudoaneurysm. The other main cause of pseudoaneurysm, venous stenosis. Several research has been done and can be the main reason. And how can we prevent from this from happening? We can do a systematic rotation of the needle punctures to the alternate size and utilizing a proper cannulation technique, sufficient vessel laxity, and by avoiding deep or superficial placement and aiming for correct depth graft and routine ultrasound can lead early diagnosis of the aneurysm and also frequent checking changes, noticing any or swelling or size, and routinely assess size. And by strategies, we can prevent this from happening, or also we can which can aid in the early diagnosis. And what are the treatment options currently available? We can do a surgical excision or ligation of pseudoaneurysm. Subsequent new graft material has to be and if the pseudoaneurysm is really large enough, this is the only option we can do. And the other treatment, which is going to be the main, so the endovascular graft. By this, avoid surgery and also the existing graft so it prolongs the life. And the third treatment, ultrasound guided injection. So the terminus can be directly injected pseudoaneurysm, which can help in that sealing of the side. But this can be only used for aneurysm. Now let's move on to the case. The patient was 78-year-old man, was admitted with graft. The left had left hand dialysis, and his past medical hypertension here and past surgery hernia related. And the major one was coronary artery surgery she had. But the patient had ejection fraction of 40% on it, so he was good surgery. On the physical exam, there was AV graft in the left arm, and the graft was patent with, but there were evidence of swelling, which we doubted. And our initial plan was to perform AV graft program to assess the size of the aneurysm, and our treatment Angioplasty and Percutaneous versus based on what we find during and permacath case the patient had a surgical excision. So after obtaining the consent, patient to the operating, and the surgery was first micro sheet and sheet upsize to 7 sheet and direct and where the is. And this was the AV graft. So the swelling in the AV graft, which is a pseudoaneurysm. And then after finding the pseudoaneurysm, exchange the 3-5 inch guide 8 guide and then proceeded to place 8 by 50 and then to the cover head and ended up and this successful complete exclusion of without or angioplasty or any surgical excision. And this was a completion venogram. You can see the pseudoaneurysm is completely gone away and there's no swelling in the picture. Great. And suture the entry side, dressing well, and no further complications and patient satisfaction. Now discussion, surgical repair versus endovascular repair. In surgical repair, the patient have the dissection of pseudoaneurysm and graft has to be placed. And the patient will also need a tunnel hemodialysis catheter to serve as a bridge for several weeks. So the patient will also need additional catheter placement, whereas in endometriosis, where the existing baby graft is preserved, and there's no need for surgical incision, and there's also no need for any catheter placement because the patient can undergo dialysis immediately after. And this can also prevent infections from happening when compared to surgical care. So endovascular is the current available treatment. And based on different studies, the most type of stents used for endovascular repair were viable stent. And in one of the patients, I mentioned that viable and wall graft is and they have that portion of these devices made such a way that they can withstand, and which is so that the patient doesn't end up being a pseudoaneurysm and procedure. So viable grafts flexible and various research. And as I talked about the case earlier, we used a viable stent in our patient for the and thus early post-procedure dialysis access impact integration in endovascular repair. In a case study, the nurses are in graft location, and they were instructed to avoid the stent for so that the stent can integrate with the graft and surrounding tissue. And there was a study which followed the simple of this underwent dialysis. The other two waited for 3 weeks, but they didn't observe a significant difference in the outcome. So it doesn't really matter if the patient dialysis immediately after the procedure or they wait. The results were same. So the early paradigm of weeks after the procedure after operation is no longer, and this conservative approach also forces the advantage of it. And with endovascular repair, no maturation of the and undergoing another additional venous access for dialysis. So endovascular treatment access advantages. And what were the long-term results and progression after the endovascular repair? Successful stent graft, exclusion of dialysis depth, pseudoaneurysm, and their long-term results were mainly based on the initial pseudoaneurysm size, and the primary results ranged from 20 to 30% for the. But those patients who had reached pseudoaneurysm had those with small pseudoaneurysm. And in one of the study, patients who underwent pseudoaneurysm had a mean size of 0.5. And in one of the studies, 2 patients required surgical repair because largest pseudoaneurysm did not decrease. Although they did decrease diameter of aneurysm, they have mentioned the largest pseudoaneurysms on cage migration sac, and thus, despite the stent placement, if the patient have larger stent, they can end up at. So, but further studies have to be done, and diameter measurements, which impacts the success rate of stent. Because undergoing stent placement may not be viable for those with large aneurysm. And the another main thing that impacted the long-term progression was venous anastomotic stenosis following repair. And as I mentioned earlier, this can primarily, and it can also be associated with graft placement for pseudoaneurysm. Thus, by efforts of successful pseudoaneurysm grafts, the limited factor dialysis graft rate defined by. So in conclusion, based on the case that I discussed today and current research, endovascular repair of graft pseudoaneurysm with stent graft option has many advantages. Like it, when compared to surgical care, it can avoid from the patient develop, and also the patient will not require additional placement, and the patient can undergo dialysis with graft. So endovascular graft placement pseudoaneurysm is effective. But the life of dialysis graft venous patients as discussed. But by excluding pseudoaneurysm and timely dialysis graft, prolonged graft preservation at climate endovascular. And that's it. Thank you all. Need to ask any guys?
Thank you. Thank you. And it's important we that have and present with dialysis related aneurysms from repeated puncture of the eye, and certainly does make it easy for patients to return back their dialysis without interference in their lifestyle. They already have to just dialysis careful, and any tension, which is mentioned, can them to have enhanced may require catheter care and cost. That proper endovascular therapy option, it can be quite the challenge, however, for patients in medical underserved communities, well, that sometimes quite graft and make available and it's talked by the organ and other questions attention and very quiet, but you can apply it practice. Our next speaker is ready, student Dr. Chris. I'm asking child. Can go along dialysis. They do have problems. They have to figure creative ways to treat. Yeah.
I'm just opening up his presentation and I'll just start presenting and then.
Hello everyone, once again, my name is student Dr. Chris Mounzer, I think medical. And so today I'm going to talk about the mother-child technique. And so the purpose of the study is essentially to evaluate the long-term outcomes and prognostic factors the age. CVS. Similarly to prolonged path. So first, like, what is the mother-child technique? So, so in a standard like endovascular therapy repair, they usually, after placing the guide wire, they place a by the port in order to insert the catheter. So in this study, what they did is instead of using the long sheath, they used a larger 7 or 8 frank guiding catheter, mother catheter, and then follow for instead of the long sheath, and then they put a 4 or 5 frank child catheter as well in order to provide kind of this double layer of catheter, more protection. So what this did is it provided an extra backup force for canalization and enabled penetration of the guide wire. So for this study, 76 hemodialysis patients with symptomatic CVS or CVO, which was defined as people having symptoms such as like swelling of the ipsilateral head, neck, or upper extremity. 71 of these cases had AV fistula and 5% of 5 cases had graft. The information was prospectively collected from September 17th to August 20th. And the indications for PTA were the obvious clinical symptoms and the central venous stenotic lesion greater than 50%. Okay. So the results. So first, it's important to understand like primary patency and second the difference. So primary patency in this study was defined as the time after the initial PTA until further intervention was needed. So if symptoms develop as vessel, then that is the primary patency. Secondary patency is defined as from the initial PTA until failure of or intervention failure of the catheter by either restenosis or reoccurrence of. So we saw over in primary patient 18 months that by the end of it, of the 50% of the catheters were still patent, and for secondary patency rate, 2 years later, 82% of the catheter patent. So what the study also did is they had some for primary patent history of diabetes and abnormal white cell count, the denominator name, and this was when primary. And then also stenting was as necessary. 15 patients received stenting in the primary PTA, and the indications for were if the elastic refill of the blood vessels, or if their time less than a month. But they found that there was no significant difference with the versus primary patient. So the mean duration of each PTA was 8 months for the first time, and then 7.5 for the second, and then 5 times for the third PTA. However, they found that there's no significant difference in the patency duration of repeated PTAs versus primary PTA. So what the study did, because there was no parallel control group, they compared different studies involving PTA in the treatment of central venous occlusion or central venous stenosis. So in each study, they included both the patency rates and how each study defined primary and secondary, which differed. But they found that the primary patency and secondary patency of this study were relatively high. So some limitations to the study was it was a single controlled cohort study. So because it was only done in one center, they weren't able to compare the mother-child technique to a controlled catheterization technique, such as using one catheter versus the mother-child technique. And there was a limited total sample size of analyzing pictures. So the risk factors included about IV of maybe an anominate vein, were could have been different if they had more patients. But ultimately, the conclusion. That's not. So ultimately, there is benefit of the mother-child technique. However, due to the limitations, there would need to be more studies done. But ultimately, 2 catheters is better than. Thank you.
Keep the access going, and so we're always constant of ways techniques to improve both our patients so they can fail. Nice talk again. Additionally, of the study is our single center study. But otherwise, but so our next presenter would, our next presenter will be Tashvin. Soon Dr. Njideaka be presenting talk shortly. And are you ready with your talk?
Yes, I'm just gonna share my screen.
Okay, share your screen and we'll let you have you. Okay.
I just want to make sure that you can see my screen.
Yeah, we see.
Okay. Good morning, everyone. My name is Timmy. I'm a student at Avalon University. First, I want to say thank you to Dr. Lee for the opportunity to present. I'm just going to be going through a quick case study titled Revascularization of Ischemic Left Lower Extremity with Anticoagulant-Resistant thrombophilia. So this was a case that we encountered during a rotation with Dr. Oye. So without wasting time, I'm just going to jump straight in. So the entire point of revascularization was because the patient actually had peripheral artery disease. So I'm just going to start with a brief overview of peripheral artery disease, and it's pretty much when there is atherosclerotic disease of the limbs, especially the lower limbs. And typically, it's very similar to what happens with coronary artery disease or with the carotid artery stenosis. And so that means that the risk factors for all of them would be pretty similar. And that would include advanced age, smoking, arterial hypertension, diabetes, dialysis. And now the most common clinical feature is actually asymptomatic. That means that the patient has no symptoms, no pain, nothing. But when the stenosis gets more and more, then symptoms start to develop. And the most common would be the claudication, which is essentially pain in the lower extremity that gets worse with exertion and is completely relieved by rest. Now, other symptoms can include cramps and paresthesia of the paresthesia distal to the site of occlusion. As the disease gets worse, then you can actually have pain at rest. And critical limb ischemia, which is when there is pain at rest for over 2 weeks or more. And at that point, it's an emergency. A lot has to be done to be able to save the patient's limb. Diagnosis typically is done first with the ankle brachial index, and when it's less than 0.9, then we have a very good inclination that this patient has peripheral artery disease. And after that, for surgical planning, then CT or MR angiography is done, and a duplex ultrasound can also be done if the patient is not able to tolerate contrast. On the picture to the right, this is a CT angiogram, and what you can see is the popliteal vessel, and you can see the blood flow in the center, but then on the side, you can see the narrowing because of the atherosclerotic plaque that has built up in this vessel. Treatments starts initially with exercise therapy, and that helps a lot with the intermittent claudication. But of course, the same idea with the atherosclerotic diseases, lifestyle modification, medical management, and revascularization of whatever vessel is affected. If it's the popliteal, then we go with that. And in this case, medical management, one of the medications that is indicated is cilostazol to open up the vessels that are stenosed. And if for whatever reason all of these don't work, that's when we go with revascularization. And if with that the patient still continues, stenosis still continues, and it affects the health of the limb, let's say if there is wet gangrene at this point and the limb cannot be saved, then amputation is the only option that will be left with, especially if the patient is septic. And with the gangrene of the limbs, then that increases the chances of sepsis happening in the patient, and it would only continue if the limb is not going to heal. So going to the patient that we saw, this was a 53-year-old male, and his chief complaint was pain in the left lower limb. And interestingly, this patient already had a procedure done. In fact, he already had a left femoral popliteal bypass in. And even with that, he still had the pain in his lower limb. He still had the ischemia of the limb. His past medical history included peripheral artery disease because he was already diagnosed before he came to us, hypertension, type 2 diabetes, with neuropathy, dyslipidemia, and he already had his left great toe amputated because of gangrene, wet gangrene due to type 2 diabetes. Social history, he was a non-smoker. He did smoke at the point where he quit, and he had no known use of recreational drugs. The relevant physical findings that we saw were on the left foot, there was an area of pre-gangrenous changes, which obviously points to the fact that there was still less blood flow to the legs. His venous flow was normal, or it was present through the posterior tibial segment, anterior tibial segment. Now, CT showed thrombotic occlusion even in the graft that had already been placed in him. And of course, this is not a good sign. And the patient was then scheduled for a revascularization procedure. Initially, he was actually meant to get an amputation because after the procedure, there was still occlusion of these vessels. And so amputation seemed like the only way to go, especially because he already had pregangrenous changes. But the patient did not want to get the amputation. And so because of that, he came for a second opinion to Dr. Oye, and he was taken for the revascularization procedure. Now, what happened in the procedure? First, we made an incision to expose the tibioperoneal trunk and the anterior and posterior tibial arteries, and then the anterior and posterior tibial arteries were clamped, and heparin was administered so that there wouldn't be a lot of clotting going on. And the incision was made distal to the popliteal artery and it's extended to the peroneal trunk. After this, a catheter was passed in, and the entire point of passing the catheter was so that we would be able to take out all of the organized clots that had formed, and this we did. First from the posterior tibial artery, and then from the peroneal artery, and then the anterior tibial artery. And I'm just going to show you a picture of just the amount of organized clot that we're able to remove from the vessel. So here you can see it was a lot, and this explains why he had the ischemia of his lower limb. Now, after we took that, we then went backwards to the majority of the popliteal artery to try to get out a lot of the plaque there. And we took out a lot of plaque, but even after doing that, and then after we did the angiogram, well, mostly Dr. Oye, but after the angiogram was done, then it was clear that there was still a bit of disease areas in the proximal popliteal artery. So we went again through the femoral artery, and took out an additional plaque from the vessel, especially at the proximal popliteal. Now, after this was done, flow was really good through the vessels. And then he went back in to put a stent to keep the graft that had been put in to keep the blood flow through it good, because of course there was already a lot of clotting and blockage going on in there. So after we took out after Dr. Oye took out a lot of the clots, blood flow was actually very good, and so he closed up the vessels that we had gone into. And then after an angiogram was done, again the popliteal pulse was good. there was good flow through that. But then the posterior tibial pulse was weak. And of course, this again would affect the foot. So Dr. A made the decision to go in there and try to take out the plaque that was obstructing the vessel. And so this is the angiogram that was done. I'm going to start with the first video before anything was done. And you can see that the blood flow was quite poor and it wasn't getting to the bottom of the foot. And in the picture in the middle, this was when he basically put up the balloon angioplasty to take out or break up the plaque that was there. And it worked because when I play the next video, you then see the comparison of the blood flow through this vessel, and you can see that it just went straight down to the foot. So blood flow was solid. Now after this, I think it was after roughly 1 or 2 minutes of closing up, pulse went weak again. And so it was clear that there was something going on in there. And at this point, we weren't sure. So Dr. Oye made the decision, because this was endovascularly done, but he made the decision to then open up and isolate the posterior tibial artery and fix it from the inside. And that was what was done. So an incision was made to expose the posterior tibial artery, and control was gained to avoid any blood loss. And then after this, he went into the vessel, and again, there was a lot of clot that was forming in real time. And this was very concerning. And in fact, when he took out the plaque or the blood clot that had formed, he closed up the artery and he checked the pulse and with a Doppler. And I'm just going to play that for you right now. And you can hear how loud and how bounding the pulse was. Yeah, so it was extremely loud. It was very clear. But then for whatever reason, after closing up, then pulse just got weak again. So the clotting was actually in real time. We did this, or Dr. Oye did this about 3 times. And after that, it was either he continues to do this because it didn't look like it was going to get any better. The clotting just kept happening. Or find a way to just ensure that this doesn't happen and close up. So he went with the latter, and by the way, this is what was taken out. In real time, this was forming. So there wasn't much that could be done. And by the way, we had put the patient on a lot of anticoagulants, and I'll get to what exactly we put the patient on. So at this point, Dr. Oye put in a graft through the groin. It was about 20 cm, went into the femoral artery. And the idea of it was just to continue to drip TPA straight into the artery to avoid any clots forming. And because patients, like I said, was already on TPA, was already on agatroban, was already on dextran, and we had given heparin as well, but patients was clotting through everything. And at that point, this was pretty much all that he could do because nothing was working. So the idea was to continue the drip and then in 24 hours, reevaluate the patient to see if that helped or if eventually the patient would still need to get the amputation and which one it would be. Would it be below the knee or above the knee? Now, after we went to see the patient, and unfortunately, the patient's limb was still cold. And what that meant was, of course, the drip had not helped. The patient was still clotting through it, and he was going to need a below-the-knee amputation. And the reason below the knee was because his foot was definitely cold, but from like shortly or a bit distal to the knee, it was warm, so there was good blood flow there. And that's why below the knee amputation was definitely a good consideration for the patient, and he was referred to that. And also hematology to see what could have been causing the hypercoagulable state because he was clotting extremely quick. And then to conclude, our patient had resistant thrombosis despite multiple revascularizations and anticoagulation therapy, and ultimately needed an amputation. Now, for the reason why this was happening, there are multiple reasons why this could have been happening. Of course, one of these could be clotting disease, and COVID vasculitis is just another thing throwing out there that could have been the cause. Excuse me. But yeah, ultimately, he had to be referred for the amputation because the revascularization procedure just didn't help. And if one of the things that I thought of is if it had been caught earlier, maybe that could have helped. But he already had a procedure done, so he already had intervention, and so this seemed to be more so about something that was causing a lot of clotting in the patient. And with that, that's the end of my presentation. These are my references. Thank you. If anyone has any questions, please feel free to ask, and I'll try my best to answer. Can everyone hear me? Just to be sure, can everyone hear me?
Yeah, we can hear you.
Oh, okay. So that'll be it for me. Thank you, Dr. Oye, for the opportunity.
Hello.
We can hear you.
Yes.
Okay, everyone. Hello. My name is Amelia. I'm next. I'm actually going to start sharing my screen. So give me 1 second here. Can everyone hear me all right?
Yeah, we can hear you.
Okay. And please, at any point during the presentation, if you cannot hear me, just yell into the mic and let me know.
All right, got it.
Okay. So first today, I'm going to talk about an interesting case. Oh, sorry. Well, let me introduce myself. My name's Amelia York. I am a third year with the DeBusk College of Osteopathic Medicine in Tennessee. Thank you so much to Dr. Oye for having me today. And thank you to everyone else that presented today. You guys were amazing. So, sorry, excuse me. I'm going to be presenting on a right carotid endarterectomy case over at Raleigh General. That was interesting. So some background information. It was an 86-year-old female that was initially admitted for amaurosis fugax in the left eye, which is a temporary loss of vision due to decrease in blood flow. And based off of imaging, it was found that she had greater than 90% stenosis of her right internal carotid artery. So it was decided that the best plan of action was to perform a carotid endarterectomy on the right side. So once access was made, it was found that this patient did have some unique anatomy compared to what we normally see with the arteries in the neck. She had a deep posteriorly located right internal carotid, an anteriorly positioned external carotid, a superior thyroid artery that crossed the internal carotid, and a low riding hypoglossal nerve. So the carotid endarterectomy was performed. We used a traditional incision and patch technique. I included these pictures up here to show you guys the plaques that were removed. So when she was taken back into the recovery room and awoke from anesthesia, she did develop left-sided hemiplegia, and she was taken to get an immediate CTA and CT of the head. And the results demonstrated that there was decreased perfusion going on, and so we took her back to the OR immediately. So once we got back to surgery, we regained access for exploration, and the superior thyroid artery was ligated to gain access to that ICA that was deep and posterior. And once we gained access to the ICA, we didn't find any blood clots or plaques that had been previously missed. So the presumptive diagnosis was that it was perhaps the patient's unique anatomy that was contributing to the decreased blood perfusion. So the ICA was ligated and reattached to the common carotid artery. So we took her out of surgery. She was admitted to the surgical intensive care unit and then intubated for stability. And she did actually recover from the left-sided hemiplegia and regained functions of all of her limbs and demonstrated no further abnormalities post-op. So what this case tells us is that in the case of development of dense hemiplegia, immediate re-exploration is indicated post-carotid endarterectomy. And just really quick to talk to you guys a little bit about the epidemiology of carotid artery disease. It's found in 5% of the population, 3% are over the age of 65, and it's the cause of 1 in 3 out of all strokes, and it's most common in white and Native American populations. Non-modifiable risk factors include age, male sex, family history, and genetics. Some of the modifiable risk factors are smoking, hypertension, high cholesterol, diabetes, obesity, stress, alcohol, and physical inactivity. And quickly, I just wanted to talk to you guys about 2 surgical interventions that are used. The first being the eversion technique. And if you follow along with my diagram over here, first, a less than 4 centimeter incision is made over the carotid bifurcation. And then the internal carotid is disconnected from the carotid bulb with an oblique arteriotomy. The internal carotid is then everted, the plaque is removed. An endarterectomy of the common carotid and external carotid are then performed, and then the internal carotid is reconnected to the carotid bulb with sutures. The other technique, which is the one that's most often used, is a traditional incision and patch. So an incision is made overlying the carotid artery. The common carotid, internal carotid, and external carotid are then clamped to create a surgical field. And then an incision from the common carotid into the internal carotid is made. The plaque is removed. And then to widen the artery and reduce the risk of restenosis, a patch is sewn into the site and closed with fine sutures. Okay, those are my sources. Thank you so much. Does anyone have any questions at this time? All right, great. Can everyone still hear me all right?
Yeah, we can hear you.
All right, great. Okay, then I will get. Hello? Okay.
Can you hear me?
Yes, I can hear you,
Hello?
Dr. Yeah.
Yeah. Yeah, the take home
Dr. Oria, we can't hear you.
the take home can you hear me now?
We can hear you now.
Yeah.
Dr. Oya, are you still there? Amelia, I believe you have another presentation.
Yeah, I do. I wasn't sure if he was still talking or not.
Yeah, okay. In that case, we can just go ahead with the second one.
Okay, all right, we can move on.
Yeah.
All right. Sorry, Dr. Oya. So the last presentation I have for everyone is a journal article on the characteristics, antithrombotic patterns, and prognostic outcomes in intermittent claudication and critical limb-threatening ischemia. So this is just a quick overview of what I'm going to be going through. So to start, just to introduce these two symptoms of peripheral artery disease, intermittent claudication involves the onset of dull and aching muscle pain that typically resolves with activity. That's due to decrease in blood circulation. And it's important to note that intermittent claudication can progress to critical limb-threatening ischemia if it's left untreated. And critical limb-threatening ischemia is muscle pain that occurs with activity.
Sorry
Yeah.
to interrupt you. I think you're still sharing the previous slide.
Oh, I started sharing the other one. Hold on.
So try well, stop sharing and then share again on the other.
Okay. Sorry.
No, you're good.
I apologize, everyone. Okay. Wait, hold on. Is that better? Can you see? It's pink and blue.
Yeah, this is great.
Okay, perfect. Okay, I apologize, everyone. I thought that you could see my screen. Okay, so I introduced the article. This is the overview. And then this is just a slide where I was introducing critical limb-threatening ischemia and intermittent claudication. And then I stopped in the middle of critical limb-threatening ischemia. So that is muscle pain with activity and rest. It involves non-healing sores and or ulcers, numbness, and then diminished or absent pulses. And it's important to note with critical limb-threatening ischemia that it does have an increased risk for amputation if it's left untreated. So the main purpose of this study that was to clarify the differences in the clinical presentation, prognostic outcomes, and outcomes post-EVT or endovascular therapy between intermittent claudication and critical limb-threatening ischemia. So this was a prospective multi-center cohort study. It involved 692 patients from 20 institutions in Japan. 79% of the cohort had intermittent claudication and the other 21% had CLTI. 81% were male, 19% were female. And their primary measurements were the characteristics, antithrombotic patterns, and the outcomes post-EVT, which we're going to jump into right away here. So, oh, dang it. There we go. So to start with the results of the characteristics, intermittent claudication, primarily male. There was an increased prevalence of hypertension, smoking, and dyslipidemia among the cohort, also with a higher prevalence of prior coronary revascularization. And there was a lower prevalence of inflammatory coagulation disorders, such as increased D-dimer, increased C-reactive protein, and also increased erythrocyte sedimentation rate. And they defined it as a proximal artery disease above the distal superficial femoral artery. And the arteries that it mostly affected from greatest to least was the femoral popliteal, aortoiliac, and infrapopliteal. And as far as the characteristics go for CLTI, predominantly female, it was associated with more disability, malnutrition, and frailty. There was increased prevalence of diabetes, heart failure, atrial fibrillation, stroke, and kidney disease, and renal failure, as well as prior amputation. These patients had a higher risk for infectious wounds and osteomyelitis, as well as a higher prevalence of inflammatory coagulation disorders. And they defined this disease as a distal artery disease below the superior femoral artery. And the arteries it affected from greatest to least was the infrapopliteal, femoral popliteal, and aortoiliac. For the antithrombotic patterns, intermittent claudication was associated amongst the hospitals was the use of short dual antiplatelet therapy during 1 month post-op EVT. And prior to EVT, there was the use of silostazole. And then for CLTI, it was more associated with short single antiplatelet therapy during 1 month post-op EVT, and then silostazol was more likely to be used post-EVT for anticoagulation. And for outcomes, intermittent claudication, they saw an immediate claudication symptom improvement in 70% of the cohort. There was claudication that reoccurred in 25%. There was a 3% progression to CTLI in the cohort, and it was also associated with lower major adverse cardiovascular events within 3 years at 20%. And then they did see a 22% reintervention rate in 3 years. For CLTI, there was immediate reduction in resting pain from 23% to 3%. There was a decrease in minor tissue loss as well as major tissue loss. It was associated with a higher MACE rate at 42% in 3 years, and then a higher reintervention rate at 47% in 3 years. So in conclusion, intermittent claudication is a proximal artery disease that does demonstrate beneficial outcomes post-EVT. And as when compared to CLTI, which is a distal artery disease that's associated with more systemic comorbidities, inflammatory disorders, and also has 2 times higher rates of major cardiovascular events in re-intervention. So some limitations of this study was that it was prospective and observational methods, which can contribute to confounding factors. The endovascular strategies, devices, and managements used across the hospital was not standardized. The clinical practice and institutional circumstances could contribute to data collection. And also the antithrombotic data didn't take into consideration the switching, interruption, or fluctuation in treatment compliance. And that is it. Any questions? All right. Well, if there are no further questions, thank you so much, everyone, for your attention. And Dr. Oye, I will give it back to you. We can kind of hear you, but it's very echoey.
Can you hear me?
Yes, Dr. Oye, I can hear you, but it echoes really badly. But just try and talk on it. Wherever the mic is at, pull that closer and that should help.
Hello, Dr. Gorgie, are you there?
Yeah, I can hear you now.
Okay. So I think you're the last presenter. Are you able to present your screen?
No, it's me, Saad. It's not Dr. Guji.
Oh, sorry.
Yeah.
Okay.
Yeah.
I think his presentation will conclude the rounds.
Dr. Goji said he won't be presenting today.
Okay,
Probably
that's
some-
fine.
Okay.
Okay, that's fine. I think that concludes it. Yeah, that being said, Sam, thank you very much. I think that will conclude the global grand rounds for this year. This is December 2024. We at this time would look forward to 2025, and hopefully we'll work out our technical difficulties for the next conference. We appreciate all the speakers taking out time today to talk on the conference, and we'll look forward to seeing you in 2025. Thank you so much.
Thank you, Dr. Aurier, and thank you everyone
Thank you,
again.
sir. Thank you.
Thanks, Dr. Oye, and thanks everyone for joining in.
Yeah, make sure it's recorded, whatever we could record. Thank you.
Yeah. All right. See you, everyone.
Yeah,
Thank you, Dr. Oye. Bye. Sad.